Good evening, everybody, and welcome to this evening's ISEH Sport and Exercise Medicine Conference Series. Tonight is a session on joint instability in sport, and I've got four surgeons and myself giving, if you like, a surgical perspective that I hope will be met by you with questions and multidisciplinary challenge as to the management of these problems, all of which affect us in our day-to-day lives. The order of batting for today will be that Nick Cullen will be our first speaker on the unstable ankle. Mazin Ibrahim will pick up on the unstable patellofemoral joint. I'm going to talk about the unstable knee and the ACL in particular. John Hutt's going to talk to us about the unstable hip. And Carlos Cobiella is going to talk about the unstable shoulder right at the very end. The way we're going to run it is to play a pre-recording of each individual's presentation to begin with, and there will then be an opportunity for a discussion for a few minutes around that topic individually. So, for example, when I introduce Nick Cullen in a couple of minutes' time, Nick's presentation will play, and then at the end of that presentation, there'll be a chance for discussion. So I'd be grateful if you could forward your questions during the presentation so that I can put them to him at the end. What we will then do is run with that format through all five presentations, and then have an opportunity at the end, if you want to ask more generic questions, to have the full panel available to you. I hope that makes sense. I hope it'll be an enjoyable and instructive evening to you. And without anything further from me, it's a great pleasure to introduce Nick Cullen. Nick is the senior foot and ankle surgeon, both at the Royal National Orthopaedic Hospital. He runs their foot and ankle unit, and at the Princess Grace. He's looked after athletes for a couple of decades or longer, and he's going to talk to us tonight about the unstable ankle. Thanks, Nick.
Hi, my name's Nick Cullen. I'm going to talk about the chronically unstable ankle and try and highlight the points that I think are important here, narrowing it down to 10 specific points. So at the present time, there is an ankle sprain epidemic in the athletic population. Up to 10% of A&E presentations are for ankle sprains, and 4.2 patients per 1,000 a year are present with ankle sprains. So this is a big problem. Most of the time we think that ankle sprains resolve themselves, but a lot of the studies show that there is significant ongoing issues following an ankle sprain. Smith and Reichel showed that up to 50% of patients had ongoing problems up to a year following their ankle sprain. So this is quite a big burden on the population and on the people who treat sportsmen. So how do we approach these? Well, I think, first of all, we have to define whether this chronically unstable ankle or the chronic ankle sprain is true instability. And if there is instability, what type of instability? So this may seem quite elemental, but there are a number of reasons that an ankle can give way. There can be structural instability and functional instability, which we'll talk about in a bit, and pseudo instability, where the ankle isn't truly unstable, but it gives us a feeling of giving way. Things that can cause pseudo instability are osteochondral lesions, loose bodies, impingement lesions. Freeman was the first to propose that it's a functional instability as well as a structural instability. What a functional instability is a proprioceptive deficit. The structural instability is where there's an abnormal movement of the ankle talus in the ankle mortise. Not all patients who have structural instability will have functional instability. So you can have people with a structurally an ankle that can move excessively in the mortise, but they don't develop the proprioception adequately so that the ankle no longer gives way. And there are a number of people who can present with a functional instability where the ankle is inherently stable, but because of the proprioceptive deficit, the ankle will continue to give way. So how do we define between structural and functional instability? Well, I think the history is absolutely key. It's important to know the mechanism of injury, whether there's associated swelling, which will give us some idea about the severity of the injury that's been sustained, and the frequency. How many times, how often between sprains does the instability happen? It's really important to dig deeper though and find out more about the nature of the instability and what the patient or sportsman means by instability. They may describe instability as a feeling that the ankle will give way. Often pain comes before the ankle giving. And when that comes on, they have a feeling and they're able to stop themselves. And they have to take the weight off their ankle to stop it giving way. But infrequently does it give way, which may be a pseudo type of instability as opposed to a structural functional instability. Or does it give way and the ankle wipes out from underneath them without any warning? So the two are quite different. Is the ankle consistently unstable? So with a structurally or functionally unstable ankle, when walking on uneven ground, walking in the dark, the ankle will feel unstable and give way on regular basis over similar terrains. With a pseudo instability, then the instability and the giving way is much more infrequent. Does the ankle lock? A killer question is, how do you manage when you're walking in the dark on unstable surfaces? Often people with true functional or structural instability will have a degree of anxiety when they're walking out of doors. A little bit of basic anatomy. What are we talking about with the majority of ankle ligament injuries? Well, injuries to the lateral ligament complex. With regards to the ankle, this is the ATFL. The ATFL is a ligament that passes obliquely along the tip of the fibula and inserts onto the neck of the talus. It's not a discrete, distinct ligament in the true sense, and is more of a thickening of the anterolateral capsule of the ankle. The CFL, you can see on the next slide, is a discrete structure, and it's more of a classical ligament. It passes quite posteriorly, so it inserts around the peroneal tubercle. And this becomes tight when we dorsiflex the ankle up to 90 degrees. And when the ankle is plantarflexed, it is not tight, it's lax, and it doesn't contribute to the stability so much. Examination, again, I think history and examination are vitally important in the diagnosis of chronic ankle instability. It's important to look at bony tenderness around the fibula, the medial malleolus, talus, to assess for any bony injuries here at all. Palpating the lateral ligaments, the deltoid ligaments, the syndesmosis, assessing the peroneals for tenderness as well as instability, and the Achilles tendon, of course. And then obviously looking at the ankle, looking at the range of movement, impingement tests anterior and posterior, which can be causes of pseudo instability. The anterior drawer test, when we looked at the previous anatomy slide, the ATFL is tight with the ankle slightly plantarflexed. So assessing this, there's an anteriorly directed force with the heel being pulled forward, but making sure that the ankle is in slight plantarflexion. If it's dorsiflexed, then the ATFL will automatically be laxed and we get a false positive result. With regards to the CFL, we can see that that's tight with the ankle at 90 degrees. So I dorsiflex the ankle, having the foot on my forearm. And once I'm sure that the ankle's at 90 degrees, assessing the CFL with this in maximal tension. So both of these are highly accurate at assessing for instability in both of these ligaments, and an extremely important part of the assessment. What about investigations? Well, I think that history and examination are the keys to defining stability, and imaging can be helpful in supporting your clinical diagnosis. So generally, we do not rely on imaging to define whether an ankle is stable or unstable. Weight-bearing x-rays are helpful to assess the syndesmosis, assess for degenerative change within the ankle joint itself, for fractures, for avulsions. Weight-bearing CT scan has come along more recently and is probably the gold standard now if access is a problem. But this will give us a three-dimensional view of all of the ankle joint, the mortise, the subtalar joint, the syndesmosis. MRI scans, it's important to understand that these are not a proxy for stability. So frequently there'll be reports that say ruptured ATFL, the ATFL is attenuated, the ATFL is unstable, but it's very difficult to assess the stability on the basis of an MRI scan. And most ligaments in ankles, stable or unstable, will look to be thickened and abnormal. The MRI scans are useful in identifying associated lesions, such as impingement lesions, osteochondral lesions, and in coalitions, which is an infrequent cause associated with instability. Stress X-rays, occasionally these can be of help. So we tend to do the stress X-rays in theatre, and again do an anterior drawer and an inversion test. However, most of the time, this is unnecessary, as we're able to assess quite nicely in the clinic setting if we can relax a patient, whether the ankle is unstable or not. And sometimes this could be reserved for a borderline case or a patient whose history and examination don't quite add up. So how do we manage the chronically unstable ankle? Well, I think non-operative management is an important first step in most ankle instabilities. What do we aim to do with physiotherapy and non-operative management? Well, to address the proprioceptive deficit, which is vital in both structural and functional instability, to compensate for any structural instability. So we may not be able to stabilize the ankle up by non-operative management, but we can compensate for it. It's important to know, and we'll repeat this again, the results of delayed surgery is equivalent to primary surgery. So there's nothing to be lost for a course of non-operative management initially. And indeed, trying to build up and close that functional deficit prior to surgery can be helpful with the post-operative rehabilitation. So with non-operative management, physiotherapy is helpful, undergoing a good course, usually 3 months of functional rehabilitation, working on range of movement, strength, proprioception, gait, the proximal chain. Orthotics or bracing or taping can be helpful, certainly in the initial instances, to prevent the ankle giving way during the early stages of rehabilitation. But as time goes on, this can become detrimental. Time out of play, trying to manage the season and the time out so patients and sportsmen aren't going back to play sports too early and going over on the ankle again. Trying to modify the training to less risky aspects to keep fitness up. Occasionally patients will have a combination of impingement type pain and instability, and an injection of steroid and local anesthetic can reduce the pain elements of impingement and provide a therapeutic window to rehabilitate the ankle in some cases. And then finally, season management. So with a lot of unstable ankles, is finding an appropriate time to rehabilitate appropriately with the least time out from sports. So with appropriate physio, game management, bracing, sometimes we can get sportsmen and through the end of the season and try and pick a time in the off season to be able to stabilize these ligaments. Trying to define when we're going to do things and the time out and the patient's expectations is very important. So when do we consider surgery? We've looked at non-operative management, but in those patients who remain grossly lax, in those patients who have recurrent sprains despite adequate non-operative management. And I've put a question mark against the acute repair in the elite athlete, which remains controversial, but in some patients with significant grade 3 type injuries, complete ruptures of ATFL, CFL plus minus deltoid, there may be a place for an acute repair. I'll repeat again that the results of delayed surgery are equivalent to those of acute repair. So there's no rush to get into repairing ankle ligaments initially without proper non-operative management. So how do we repair ankle ligaments? Well, the gold standard is probably the Brostrom-Gould anatomical repair. This is a double breasting of the ATFL and the CFL ligaments, and then a reinforcement of the inferior extensor retinaculum over the top of this to the periosteum of the fibula. It's extremely rare that we go in doing a Brostrom-Gould repair and find that there are two ruptured ends of a ligament. It is the case with the CFL that we can find the end of the ligament, and sometimes that hasn't attached back. But with the ATFL, there is always a sheet of tissue, and these tend to be intrasubsistence stretches, or laxity at one end or another end. So we don't go in and have to find the two ends of the ligament. We go in and we divide this ATFL and the scar tissue there, and then double breast it and tighten it up with the ankle in a reduced position. There's something that comes up regularly now that there's a vogue towards using the internal brace. And this is simply some fiber tape, an extremely strong suture, which is put on with two buttons between the fibula and the talus. And this may allow, in recurrent cases, large patients or patients waiting for an accelerated recovery, to rehabilitate a little bit quicker, theoretically. With a good Brostrom-Gould repair, there's little need in most of the cases to use this. And one of the downsides from using thick suture tape like this is actually over-tightening the ligament repair. We can see that the Brostrom-Gould repair restores almost normal kinematics to the ankle joint. So this is the type of approach that we might use. This is an incision skirting the tip of the fibula. And you can see here, this is not what we find as we go in. The ATFL has been divided. You can see the two ends of ATFL are 2 and 3, and 1 is the talus underlying this. And we can see there's no discrete ligament of the ATFL. This is a thickening of the capsule either side. Here is the CFL, which in this case is actually intact. And you can see this is more of a discrete ligament, and it's passing down quite deep to the peroneal tendons. In this case, we didn't need to repair it. And this is the kind of thing we do. This is a double breasting type suture where we tighten these opposed sutures up, making sure that the ankle is reduced back into its normal position in a reverse anterior drawer position, or an everted position when we're doing the CFL. We all have seen on Google and in the textbooks the ankle ligament reconstructions, and these are the complex weaves of either allograft or peroneal tendons. And I think every surgeon in the 50s, 60s and 70s defined a different way of repairing the lateral ligaments. So these can provide very good stability. The issue with them is that the complication rate is higher. There's an increased risk of nerve damage, increased risk of over-tensioning of the repair, and it doesn't restore normal kinematics like a Brostrom-Gould repair. As well as that, with the ones that use the peroneal tendons, that sacrifice the peroneal tendons, and most of the time, this is unnecessary. We do some ligament reconstructions, and my preference is an anatomical reconstruction using an allograft on top of a Brostrom-Gould repair. But these tend to be in revision cases in patients with significant hypermobility. What about post-operative rehabilitation? Well, following a Brostrom-Gould type repair or a reconstruction, patients tend to spend a couple of weeks in plaster to rest the wounds and get over the surgical aspect of the inflammation. Between 2 and 4 weeks, they're placed into a pneumatic walking boot, and then 4 to 10 weeks put in an ankle brace. Physiotherapy can commence from 2 weeks. Initially, that's reducing inflammation and swelling, working on range of movement, notably dorsiflexion, avoiding any inversion or excessive plantar flexion. They can begin some closed chain exercises as pain allows, and they start firing the peroneal tendons and doing open chain with the peroneal tendons very early as well. Proprioceptive work can begin between 4 and 6 weeks with bilateral and then single leg standing. And jumping, hopping can begin at about 8 weeks. With regards to return to sport, I think it's very important, depending on the level of the athlete, to set expectations early. And expectations and the recovery time and return to sport will depend very much on the severity of the injury, as well as any associated ankle pathology. As a general rule, non-elite athletes will return to sport at 12 plus weeks, and that's usually returning to training. The elite athletes tend to recover much quicker. Calder et al. Looked at a study, a cohort of their patients, and found that on average they returned at about 10 weeks following surgical repair. Thank you.
Nick, thank you very much. Thanks for doing that, and it's really a very big, broad effort. A few questions for you, and a reminder to our audience that if you put questions on Slido, they will eventually be forwarded by our team to me here from that point of view. So Nick, if I got your message right, it is really clinical assessment that's the heart of this, and if anything, it's much more important, the imaging. Is that correct?
I think that's absolutely spot on, Faris. I think a good clinical assessment, taking care to work out what's happening in the history, replaces everything. And I think the imaging is an augment to that. But I think we open ourselves up to over-diagnosing instability if we just rely on the imaging. So trust your clinical acumen.
So turn it around another way. It is, I remember back in the day learning all the Ottawa rules for when to x-ray an ankle in casualty and all that sort of stuff. You know, when should we be MRIing, you know, the inversion ankle injury in an athlete? How early to MRI scan and when to MRI?
I think if you've got access to MRI scanning, I think getting an MRI scan early is helpful, especially in those severe grade 2, grade 3 sprains. I don't think it necessarily helps you define whether this ankle is going to be unstable or not, but I think it helps exclude some of these occult type fractures that you can see. We've all seen those surprises on MRI scans where you've taken a dent out of the plafond. It helps us look at the syndesmosis and exclude the high ankle sprains. And it also tells us a bit about the bone bruising in the talus. And I think getting an MRI scan in the elite athlete setting is helpful, because I think it helps in expectation setting and defining exactly what that injury is and making sure that these things aren't picked up further down the line. Because in the elite athletes, I think picking these things up at 4 weeks, 8 weeks, 12 weeks down the line, it can delay their return to sport. And if we can pick these abnormal ones up, it's much more helpful. And it is helpful in picking up these associated injuries, which when we look in the ankle are quite common.
So talking of which, you mentioned the syndesmosis there. How often are you seeing missed syndesmotic injuries? You know, do we need to be more careful about diagnosing those early?
I think these are one of the common ones, the syndesmosis injuries, the Lisfranc injuries. These are very commonly missed. And so I think with access to MRI scans, that can be helpful. But I think we should always be vigilant in these very swollen ankles, ones that are painful to weight bear, whether there's been an associated syndesmotic injury. So I think these are things that we frequently see in clinic that have just not shown up early on, and they present with a delayed return to sport and the ankle sprain that doesn't settle.
And I take it the rehab then, the salvage is tougher if you get them late.
Well, if you've had a significant syndesmotic injury, that it's really difficult to recover. And I think the defining these things early, when the athletes have been there rehabilitating for 3 months and doing everything right, and the ankle's been letting them down, I think it has a big negative impact on their proprioception and the confidence in the ankle, as well as it being more difficult to treat surgically.
That sounds spot on with my experience, Nick. Is there any evidence or role for prolotherapy or any other injectables around the ankle?
It's something I don't use, Ferris. I think it seems that every year there's something else that's clever to inject here. If you've got an unstable ATFL or CFL, in my opinion, I don't think this is hugely beneficial. Maybe it's the cohort of patients I'm seeing, and the patients who present to my clinic are grossly unstable and they've been through the mill and they've had everything tried beforehand. But it's something personally I don't use.
No, that's fair enough. You alluded to potentially in a very nice way to the fact there may be some over-aggressive surgery going on acutely and that the results aren't different if you wait and see how people go.
Yeah.
Is there a big downside to early surgery?
There's definitely a complication rate with lateral ligament repairs. So nerve injury, common ones, nerve injury, bulky repairs that lead to anterolateral ankle impingement. So for these severe sprains, the patient who may have had intermittent severe sprains, possibly, but we can't ignore the fact that the surgery has a complication rate. And the results from non-operative treatment are very good. So there are multiple reports in the literature that patients will get back to a good level sport with non-operative management.
Last question, Nick, it's one from the audience again, is how influential do you think a patient being told, effectively on the basis of a scan, that they're unstable, how influential is that in promoting fear avoidance or other negative impacts? Do you think you ever overcome that message they've got that the ATFL is torn? Because lots of people torn ATFLs functioning very well, aren't there?
That's a really good question, and it turns into one of these sort of post-traumatic debriefing scenarios where trying to build the patient's confidence that these things aren't ruptured, and many ATFLs look very abnormal on an MRI scan. So I think it's really difficult, and I think that because patients get it in their head that this is a rupture, but I've been told it's a rupture. So I think trying to get our nomenclature right and trying to work with our radiologists about how we term these things is quite helpful.
All right, actually one final question just come up. Sinus tarsi presentation and instability. Should you address the instability first or early MRI scan to assess for impingement?
I think subtalar instability is a really difficult one to pick up. And I think an MRI scan in the elite type setting, I think an MRI scan is really helpful to have a look at that. But always, there will be a functional element to trying to stabilize that up once you have a diagnosis. But working with an early diagnosis is helpful.
Nick, that's fantastic. Thank you. So comprehensive and superb. There'll probably be a chance at the end potentially for more generic questions, but thanks for a great presentation and thanks for joining.
Thanks.
We're going to move up to the knee now, and Mazin Ibrahim, who's consultant orthopaedic surgeon at the Whittington and UCLH and at the Princess Grace, is going to take on the tricky subject of patellofemoral instability.
Good evening, everyone. I am Mazin Ibrahim, consultant orthopedic surgeon. I'm going to talk to you today about the patellofemoral joint instability or the unstable patellofemoral joint. Patellofemoral joint instability presents a challenge to all surgeons, and it is really difficult to define because it is not one condition. It is a spectrum of conditions, and it is multifactorial. It can be traumatic, can be related to ligament laxity, but also can be related to anatomical structure variation, leading to patella dislocation or the full spectrum of patellofemoral instability. It usually affects these people mainly in second decade of life, and the incidence in this age group is between 3.8 to 29 per 100,000. It is definitely a challenging condition for all the surgeons, and many people over the years have tried to define it with a single definition, but they failed to do so. There are classifications to describe this spectrum of diseases, as we can see from the Dijon classification, who put lots of efforts in this subject. And he classified it into an objective patellofemoral instability or dislocation, where you have documented evidence of dislocation combined with one or two or more risk factors, anatomical risk factors, combined with anterior knee pain. The other part of the spectrum is the potential patella instability or dislocation, where you don't have actually documented evidence of the patella dislocated, but you have all the risk factors leading to that, like anatomical variation, but also anterior knee pain. The last part of the spectrum is the patella pain syndrome, which is a wide range of pathology, which can be even not related to instability. Because it's difficult to define, so it is difficult to diagnose. And it's definitely not easy to diagnose this spectrum from only clinical examination or clinical findings. Definitely we require a thorough history about what's happened, the mechanism of injury, and how did it happen. But also clinical examination is crucial. And this doesn't include only the patellofemoral joint. You need a holistic approach for the examination. We need to look at the muscle balance. We need to look at the alignment in general, including the whole lower limb. Because there are many factors and many reasons why this can happen. In the acute setting, it is definitely easy to diagnose when there is documented evidence that patella dislocation or a lateral subluxation happened, where the patient felt it, and it was documented dislocation, which was reduced either by the patient, spontaneous, or by the paramedics. We can see on the picture on the left-hand side, there is a patella dislocation. And when you see this picture, you will realize immediately that actually there is patella dislocation. But sometimes the diagnosis is difficult when patients present only with anterior knee pain, a feeling of a clicking instability, which is not easy. On the other hand, as we can see in the video here, we can see clearly patella subluxes through the range of movement. In the chronic setting, sometimes it can be more subtle and it's difficult to diagnose. But there are many tests available which are operator dependent with different sensitivity and specificity. For example, the apprehension test, which I always find it good and reproducible. When I push the patella laterally, patient will feel something, they will be apprehensive. Sometimes they stop you, and sometimes they say, well, it's going to dislocate, please stop. Patella tilt test, quadrant test, J sign, abnormal patella tracking, these are all tests can be performed to confirm the diagnosis. The key point here, that clinical diagnosis might not be enough to confirm the presence of patellofemoral instability and should be combined with other modalities. For example, radiological evidence of patella dislocation or the patellofemoral instability can be helpful to confirm the diagnosis. There are also anatomical risk factors can lead to instability and can lead to first dislocation if it is combined, for example, with the traumatic event that lead to that, but also sometimes even without a trauma. People, they try to define many risk factors. These risk factors can be local within the knee, can be distance within the hip, for example, femoral anteversion, excessive femoral anteversion, external tibial torsion, which is more local, or it could be static or dynamic. Dynamic related to the muscle bulk, muscle strength, and this doesn't include only the quadriceps and the VMO. Also can be the hamstring, the glutei, the external rotators of the hip. Therefore, this is all can be confirmed clinically, but also radiologically. De Jor tried to identify risk factors in his publication in 1990, and he was able to identify 4 major risk factors, namely trochlear dysplasia, patella alta, excessive TT-TG distance, and patella alta. However, later, with the advancement of knowledge, patella tilt became a consequence of the 3. I find it to have easy and simple radiographs is very useful. However, cross-sectional imaging like MRI scan and CT scan is very useful. And especially in the acute setting, I find the axillary view of the MRI scan, the axial view of the MRI scan is very, very useful because it tells you about the trochlear dysplasia, it tells you about the MPFL integrity, the subluxation, the presence of osteochondral lesion, which helps later on tailor your diagnosis and tailor your management plan. The key point here, combining radiological evaluation with the clinical assessment, looking at the risk factors for patellofemoral instability is crucial. To move on, as I mentioned, this problem is multifactorial. It's a wide spectrum. Definition is difficult. Clinical diagnosis is difficult. Treatment will be challenging as well. It is easy probably in the first dislocation, where you have documented evidence of first dislocation, whether it's a traumatic or atraumatic, because most of the time the treatment is non-operative. Unless, for example, in the adolescent or even in the adult, when you have a large osteochondral lesion that affecting the range of movement, causing locking, or coming from the weight-bearing area, we might require urgent operation to deal with that osteochondral lesion by either excising it or fixing it back into where it should be. So in the acute setting, probably you have easy diagnosis, easy treatment, which is mainly conservative unless there is osteochondral lesion. On the other hand, chronic dislocation or recurrent dislocation can be challenging, and the treatment might not be only by one operation, which can be a combination of multiple operations or even within one operation by different modalities. And there are many algorithms to make life easier and direct the surgeon thinking process. For myself, I use the Leon algorithm, which I find it easy to follow, but I have my own modification. Sorry for the slide, slightly crowded, but I think it's valuable and easy to follow. And if we look at the algorithm, on the right-hand side of the algorithm, where we have the gray shaded area, is the objective patella dislocation, where we have documented dislocation, multiple dislocations, especially in the athletes, also the younger population. Operative treatment will be the solution. And this should be done after failing the conservative treatment, because in most of the time, conservative treatment in the form of rehabilitation, physiotherapy is important. And when this fails, then operative treatment is the solution. There are so many modalities, so many operations can be performed. However, which operation to choose is based on the anatomical risk factors available and the patient condition, based on the clinical examination history, but also the anatomical risk factors. MPFL reconstruction, I consider that as the most important operation, which can be combined with any other modality, because MPFL is the check ring for the patella. And if we look at the lower part of the algorithm, we have the 4 risk factors as defined by de Jor. Trochlear dysplasia, which was defined by de Jor, but also we have a new classification, which is the Oswester-Bristol one. But for myself, still, I use the de Jor because it's easy to follow, easy to interpret. However, the newer version of the classification has a better inter and intra-observer reliability. So, for example, de Jor type A, which is a shallow trochlea, the shallow sulcus, probably you can treat non-operatively. To move on with the types, for example, B and D, when you have a convex trochlea, you might require a deepening of the sulcus by doing a trochleoplasty combined with MPFL, which has a good tracking record in the literature. The other type, for example, type C, where you have higher lateral trochlea with hypoplastic medial, probably distalization plus minus medialization of tibial tubercle osteotomy might be beneficial. The other type, when you have patella alta, tibial tubercle distalization might be the solution combined with MPFL, and so on. On the other side of the spectrum, where you have potential patella dislocation with no confirmed documentation of the patella dislocation, non-operative treatment in most of the cases is the main treatment modality. Whether we treat non-operative or operative, it's important to rehabilitate the patient, especially the athletes, in order to achieve the main aim of the treatment is to prevent further dislocation in the future and to go back into the pre-injury condition. And this will bring me to the main subject of the talk, which is return to sports for the athletes, when we allow them to go back. And this is variable in the literature. There are so many publications and studies to talk about when do we get them back into sports. For me, I decide based on the patient recovery, but also based on certain criteria. And these criteria include, for example, absence of pain and effusion. It's mandatory to get that in order to get the patient back to their activity and their training. Complete range of movement is mandatory. Symmetrical strength, i.e. having good muscle strength and bulk and control, almost similar to the contralateral side. And finally, accident and dynamic stability, which can be measured by a variety of ways. Can be done by video recording, video feedback, but also with strengthening exercises and certain tests that you can achieve to do that. As I mentioned, the key point here is what we aim from the treatment, is to get back into the pre-injury level and to prevent further dislocation. But the most important thing is to get back the muscle strength and the balance and the dynamic stability before allowing athletes to go back to sports. And this requires good education combined with good communication with the coach or the physiotherapist who's dealing with this person, and it is a multidisciplinary approach. There are, as I mentioned, many publications, many studies. However, we lack high quality studies and high level of evidence to confirm when we can allow these patients to go back to sport. For example, we have Chatterjee et al. They looked at the return to sports following bony realignment surgery, and they found it in between 2 to 6 months. On the other hand, Platt et al., they did a systematic review and meta-analysis on patients going back to sports following patellofemoral ligament reconstruction, and they found nearly 93% of the patients, they go back to sports with a mean time of 6.7 months. To summarize, PFJ instability is a spectrum of conditions, and it is multifactorial. Clinical assessment combined with radiological assessment is crucial for decision-making process. Risk factors are important to identify, and treatment can be a combination of many modalities rather than one single operation. Education is important and crucial, and return to sport based on certain criteria, and the aim by the end of it is avoiding any recurrent dislocation and achieving the pre-injury level. Thank you very much.
Mazin, thank you very much, and well done for spelling it out so clearly. So if we take it simply back to the initial assessment of patients, what should be the indications for imaging after a patella dislocation? Let's say someone's had a patella dislocation and it reduces spontaneously or is reduced on the pitch or on the court, and then they come in Do you have specific indications for when you would do an X-ray, when you would do an MRI scan?
Yes, definitely. So to start with, following the initial injury, definitely following the clinical examination, if I have any feeling that there is any chance that there will be intra-articular lesion, or if there is any injury that might affect range of movement or their recovery and returning them to their activity, I would definitely image. I will start with simple investigation, AP and lateral radiograph, skyline view, to look if there is any obvious osteochondral lesion. And if I feel that there is suspicion, I will go directly with MRI scan.
So I think you've answered one of the questions already, which was, what is the best way to diagnose OCD? Is that something you typically see on the X-ray, or is it an MRI scan thing?
Well, sometimes you can see it on the X-ray. I have a few cases where I X-rayed them, and immediately I realized there is osteochondral lesion from the X-ray. To confirm that further, I go directly for MRI scan.
Okay, and you typically would definitely see it on an MRI scan, wouldn't you?
So far, most of the time, yes.
Now, is there ever a first-time dislocation where you wouldn't do the imaging?
Yes. Definitely, if the patient described the dislocation clearly and they had a spontaneous relocation, and actually the level of effusion and range of movement recovered quickly, and the X-ray is clear, I will not go for MRI scan. I will rehabilitate, do physiotherapy, get them back to their normal level and see how it goes. If they have another dislocation, then I will go for MRI scan directly.
And is there a role for aspiration?
There is, especially in huge effusion. I had a patient a couple of months ago. He is I think he was 17 years old. He's a big guy, muscular, and he had patella dislocation. He had a huge effusion. He couldn't even bend even 20 degrees. And looked at his X-ray, there was small osteochondral lesion. I aspirated him, and actually he did very, very well to get back his reasonable range of movement. Definitely I did MRI scan, but then it helped him a lot to avoid him having operation. However, by the end of it, when I got the MRI scan, and he had large osteochondral lesion, I ended with arthroscopy to deal with the lesion.
All right, and so if you operate on these guys, you clearly can deal with the articular damage. Do you routinely then do something about the patellofemoral joint at the time?
It depends. If there are obvious abnormalities where I can do something, for example, if the MPFL is completely avulsed and there is big osteochondral lesion, I'll try to do something at the same time. Having said that, recently, most of the cases I dealt with, I didn't do anything apart from dealing with the osteochondral lesion, wash the knee, get them back to physio, get back the range of movement, and actually didn't have any problem after that. So it's depends on the case, what's happened, the abnormality that they have.
And do people ever repair the MPFL these days directly as opposed to reconstructing it?
Yes, in the acute setting, if there is clear avulsion and the patient, it's obvious they have, sometimes even I've seen a couple of cases where there is actually bony part also avulsed with the ligament, you can directly repair them. You can reinforce with reconstruction, but there is evidence also if you do direct repair, they do well in the acute setting.
All right, Ian, a very good question here about lateral release. Dejour has recommended lateral release for abnormal tilt. Do you think there is a role for lateral release these days?
Not really. I don't think so.
Okay, very, very good. Excellent, Mazin. Well, thank you very, very much indeed. We may come back to you later, but in the interest of time, we should progress to the filler presentation, which is my presentation, talking about largely about ACL instability. So we'll put that on, and then feel free to put questions in the chat. Otherwise, I'm not going to ask myself anything. So please put questions in the chat. Thanks very much. Hi, everyone. I'm going to talk about the unstable knee. Clearly, I can't talk about everything to do with the unstable knee. So I'm going to focus a little bit more on the ACL than on other things, but I'm happy to take questions on any other aspect of knee instability. In terms of the bigger picture, we need to recognize there are many contributions to knee instability. Mazin Ibrahim is going to talk to you about patellofemoral instability, but weakness, whatever the cause, can be a cause of instability. Meniscal lesions can cause a presentation with instability, and knee ligaments, of course, will do the same. So the plan, as with the other presentations, is to talk about 10 key features of instability with a focus on the ACL, although not exclusively about the ACL. And in reality, the principles will apply to many other things. Now, knee instability due to ligamentous injury is common. And the most important thing is drilling down into the history and examination. Too often now we're beholden to scans, and it's remarkable how often I see patients for a second or third opinion when they are surprised that I want to examine them. Indeed, they're surprised that I want to examine both knees to get a benchmark and a comparator. So drilling down into the mechanism, into quite what happened, is really very useful. It allows you to start to understand the story of that injury in that knee, and then examination will allow you to drill down and get detail that actually is far more useful than the imaging. Both will correlate to some extent in the end, but clinical examination is key. And whilst recognition out there, particularly in our A&Es, is an issue, one way around it is to get people into the pattern recognition side of things. If someone has a twist and here's a pop or a crack, if they have rapid swelling suggestive of hemarthrosis, if they can't carry on, if they give out the next time they try and run or twist, or if they come back a few weeks later and give out again, you get an idea and a pattern that you can build from. The other big thing is to understand these mechanisms. So for example, for the ACL, we know that they're more often actually non-contact rather than contact. So that removes one big fallacy. ACL injuries can often be isolated, again, more often non-contact than contact, but can happen in both ways, or they can be combined with other knee ligament injuries. And these can be non-contact, but these are often seen with contact injuries where multiple structures are injured at the same time. So by history, clinical examination, and the imaging, we build a picture. Now, in terms of examination, I'll just focus on the ACL. It's key to understand the relationship of the tibia and the femur and to know the simple tests that we do, the Lachman, the anterior draw, and the pivot. And these can be easiest immediately after the injury. So if you look here, you can stabilize the thigh with one hand and then just move one against the other, and you'll see the positive Lachman test. If you're struggling with your hands to get around, you can put your thigh under the knee, which will make it easier. The anterior draw is important because it's important to differentiate between anterior and posterior instability. So here you can see the tibia overhanging, sitting in front of the femur, and then moving further forward, which is suggestive of ACL laxity, whereas if it falls behind the femur, then that is PCL laxity. Most importantly is not to be scared of the pivot shift test. Internal rotation, valgus force, and flexion, and you can see the knee jump there as that takes place. That's pathognomonic of ACL laxity, and is in fact showing you here on the right what happens at the time. That's really quite significant in terms of trauma to the lateral meniscus and the lateral compartment, and will explain the bone bruise. On the basis of that, you need to get the right imaging. And we typically will start with plain radiographs because you can have fractures and other injuries. The key ultimately is going to be MRI scans, because those not only show you the ligaments, they show you the menisci, they show you the bone bruise patterns, which are often very indicative of what goes on. And the big message with imaging is look at the scan, don't just look at the report, because the scan will really give the game away. The big issue here is that you can't manage everybody the same. Bespoke management is the way now. Elites need one pathway, the sporty need another, and the accidental victims, particularly the skiers, often will need a completely different pathways. And I break patients down into those who need early, almost immediate management, those who should have delayed management, and those who can have optional late intervention. Although it's disconcerting not to have a decision early, sometimes it's possible to wait and see what happens. And so there's a balance between what that patient needs as an individual and what their injury demands, and finding that middle road. And we try and build a pathway and clarify that pathway early on. The decision making will depend on many things. It'll depend partly on the injury complex, the combined ACL, meniscal tear, complete post-lateral corner injury is very different from an isolated ACL. Is there a risk to delaying, particularly with a big meniscal injury that's displaced or that should be repaired? And we should look at the risk of future problems if we deal with things early or if we don't. So if someone has a bony alignment issue, it may make sense to deal with that at the same time later on, rather than operating early. And we always have to manage the patient as a whole, their psychology, their compliance, their rehabilitation potential. That may trump the injury complex. So some patients may need reassessment, but most it'll be clear relatively quickly. What options do we have? Well, clearly non-operative repair or reconstruction. And we're talking about the ACL, but you can extend that to other ligaments. Bear in mind that many ligaments heal, particularly those that are extracapsular, but even the intracapsular ligaments will sometimes scar and heal if you have the right kind of tear. This is one of my patients. The image on the right is 4 years after the image on the left, and that ACL has reconstituted. It's not perfect, but she's about to do a ski season. It is absolutely okay to live with that. Frobel did this randomized study that you'll all be aware of ACL reconstruction versus rehab and potential late reconstruction. And that's a really important study. It's got its weaknesses about who the population is and excluding the problem cases early and whether it translates to your patient. This certainly doesn't translate to elite sport, but outside that population, the fact that they followed this study up and looked at it in detail, what they've basically done is that they've shown that in a randomized study, there are a high number of patients, slightly more than half, who can be managed with optimized rehab and don't need a reconstruction. That doesn't mean that everyone doesn't need a reconstruction. It means that if you're managed non-operatively, only about half the patients over the next 5 years will end up with a delayed reconstruction. Now, some of them may have downgraded their activities, some of them may accept instability, but the reality is that only half of those patients treated with rehab ended up with a reconstruction. And in terms of early and short-term follow-up, those weren't disadvantaged in terms of meniscal injuries or secondary surgery. So there is something to be said for early non-operative management outside the elite group. The thing lots of people worry about is the natural history and wanting to intervene for the natural history. The reality is that the natural history is set the day you have the injury. There's primary damage to the articular cartilage, to the subchondral bone, and then you see the secondary insult, the inflammatory response that happens in an injured knee that can be really very persistent, the change in bony shape that we see after an ACL injury that surgery doesn't reverse, and ongoing instability or changes in biomechanics. So we shouldn't intervene for the natural history. We should intervene for stability, which in turn can help. But for the natural history, the argument is you can wait and see what happens. Now, in terms of critical things that have happened in the last few years, ACL repair rather than reconstruction has had a bit of a rebirth. It's probably been a bigger rebirth than is ideal based on the evidence, but it is something that's out there. The big push, of course, has been commercial. People have wanted to operate on patients and do a repair because it sort of seems to be a nice thing that can be done quickly, and it's not as invasive in terms of donor site morbidity as reconstruction. I think there's likely to be a role for this, particularly in the avulsions, the femoral avulsions in the adolescents, but in the rest, there's very little evidence right now that is superior to reconstruction. And it may be pressurizing some patients into acute surgery. And ultimately, in terms of everything we know from the basic science, just putting stitches across without some form of biological enhancement isn't likely to be the answer. So right now, that's something for which there is a big push, but it's only indicated in a small minority. It can compromise later outcome. I've seen many patients that we've had to revise from a repair to a reconstruction, having to remove hardware. It's not always straightforward, and it's a very disappointed patients. So more study is needed, but there is one good basic science study from Martha Murray, who's been one of the real proponents of this, of doing it properly, suggesting that this will have a role to play in future, and we should watch this space. Reconstruction clearly still the standard of care for active patients, but they need to prehab, they need to be counseled appropriately. It's arthroscopic these days, and remember, in a reconstruction, we need to manage all the other adjunctive pathologies and the knee as a whole. But this works well if it's done properly. The big message these days of reconstruction is that surgical technique matters. The more critically you look, the more the problem is people getting it wrong, and particularly in terms of tunnel malposition and graft related problems. And it's not easy because we keep changing what we do. So the operations become a more complex operation in terms of the detail, but it's become a more straightforward operation in that more people are doing it. And that itself may be a problem. We should almost certainly be focusing on high volume surgeons doing this correctly, and particularly doing the adjunctive surgery right. I think we have a pretty good idea of the anatomy of the ACL now and what we're aiming to do in terms of anatomical reconstruction, and we can generally hit that target, but that target will be different for different people, and quite what you do for each patient will depend on that patient rather than on having one set rule for everybody. So the other issue, of course, is graft choice, and one size does not fit all. You shouldn't just have one technique. The surgeon clearly has to be comfortable, but it will depend on the patient, on their functional needs. You certainly wouldn't want to sacrifice hamstring in a sprinter, but you wouldn't necessarily want to sacrifice extensor mechanism in someone who kneels or does a lot of jumping. And you need to beware the associated instabilities. And that's where having surgery in a unit with surgeons that do hundreds rather than small numbers will make a difference. The choices, they're known to all of you. I think the new kid on the block the last few years has been quads tendon, which actually is a very good graft material. It's a viable alternative out there. What do we know? Well, I think we know that in young patients, allografts don't do well. Higher infection rates, higher failure rates. So if you are going to need use allograft, it has to be in the older patient, and they need to be informed about it. We know that both BTB and hamstrings do well in multiple randomized studies, multiple registries, probably a slightly higher failure rate with hamstrings, but higher ongoing complaint rate and stiffness in the BTBs. If you look at the higher failure rate in hamstrings, the really interesting things mostly seems to be in young females under the age of 25. And when you really probe, the problem isn't so much necessarily the hamstring, it's the small graft sizes. If you have an under 8 millimeter graft, you have a higher revision rate. If you go above 8 millimeter, you're basically putting a bigger, stronger graft in, and you do much better. So the devil's in the detail, and probably the key thing is going to be graft size in this setting. Other key messages are, of course, you must never consider the ACL in isolation. Always remember how the importance of meniscal repair and meniscal preservation, particularly the lateral meniscus, and looking at the other ligamentous structures. I think that's one of the big causes of failure, is not dealing with the other adjunctive injuries so well. The menisci, always think about root and ramp lesions, always try and repair them. That's an indication for going in early. The MCL, we're repairing much more than we used to because we understand the deep MCL tear now, and we also understand the tibial-sided avulsion that needs to be put back down. You can brace and reconstruct later. In the elite, we tend to do them early on. And the posterolateral corner best picked up early. The other big change that you need to be aware of is the extra-articular tenodesis, that understanding that we control rotation much better by doing something on the outer side of the knee rather than just an intra-articular tether. We tend to go slightly more horizontal now with the ACL reconstruction in order to be anatomical, but we need help controlling rotation. And we tend to do an extra-articular more and more in those with a strongly positive pivot, those who are hypermobile, particularly with significant hyperextension, in the elites, and in others who are high risk, particularly revision cases. Prehabilitation and rehabilitation are critical. I'm not going to dwell on those today, other than say that everything else is wasted unless we get the psychology and the rehab right. And the last thing I want to stress, perhaps unusually as a surgeon, is I've already told you the natural history is set. So an ACL injury is a disaster for that athlete, certainly at least in the long term. We can get them back to their sport. We can get them back to their sport very well, but the long term is not good. And so we need to really focus now on preventing these injuries. There's really good data out there. There are now some apps and other ways of doing it. We need to make prevention a focus nationally and internationally. So in summary, I've run slightly over my time. I think for knee instability, there are 10 keys to success. The first and most important is that clinical assessment should be at the heart of what we do. We need to get the correct imaging and look at it ourselves. We cannot have one rule for everyone. Patients need bespoke management, ideally in a high volume unit. The natural history is a problem, and that's why number 10 is prevention. In terms of current treatment, ACL repair has had a rebirth, but it should be a small part of our practice. Reconstruction is the standard of care, but you need a big enough graft, and technique is really important. And we must never consider the ACL in isolation, and we must always have prehabilitation and rehabilitation at the heart of what we do. Thank you very much. Right, well, I recorded that between Christmas and New Year. I reckon I was quite depressed listening to it. So thank you for bearing with it. There's some questions in the chat. First one is, how do you feel about taking the graft from the non-injured patellar ligament, or in fact from the non-injured leg? That was a big vogue. Don Shelburne particularly popularized that. I have to say, I didn't see the outcomes improving dramatically by doing that. The concept of taking a contralateral graft is to minimize the hit on that injured knee and share it with the other knee, but actually giving someone numbness and a scar, often difficulty kneeling, isn't entirely benign. So it's not something we routinely do. We do it for some revisions because I think autograft is better than allograft, but in principle, it has to have an indication for that patient. The next question that's come in was the concept of a cyclops lesion following ACL reconstruction. How often do we see these, and what management strategies are there? Well, a cyclops lesion effectively is a scar that forms at the front of the knee, blocking extension. That you often see that from ACL injury without a reconstruction, just from the curled up ACL that blocks extension. You can get them after ACL reconstruction, sometimes through technical error, sometimes through a partial tear of some graft fibers, and sometimes because we try and preserve the stump for vascularization. The reality is that we try very hard to make sure during the operation that it's not going to impinge, and we check that at the end. But occasionally, if someone has a partial tear or they form some scar tissue there, it happens. And quite frankly, you're not going to resolve an extension block like that non-surgically. It's a minor operation to do an arthroscopy and deal with it. There's a couple of rehab questions about a neuromuscular training approach versus strength training. I think the reality, like all these things, it's a bit like, do you use free weights or machines? I think you have to combine the two. The whole idea is to give the patient the right mix of the two. And there'll be many people on this webinar listening who have more skill than me in defining the right rehab programs, but it's quite clear that you need a combination of both. A couple more questions before I pass it on to John Hutt. One is with regards to the ACL patient returns to skiing, what are the recurrence rate and what things can the patient do to, I don't understand the rest of that question, but essentially I think to stop re-tears. I think the key thing is, get the right operation, get it well done, and do the right rehab. Like all of these things, don't go back to skiing until you are strong and functionally deemed fit by your physio and your surgeon. And for a lot of people, I think it's sensible to use a brace early on. I think all of you who are sports fans will recognize the footballer, an elite person, incredible physical specimens. When they come back at 6 months, 7 months, 5 months, or 10 months after an ACL injury, they don't look the same for several months. It takes a long time to get real strength, coordination, proprioception exactly where you want them to be. And I think that's reflected in everybody else as well. So first ski season back, there's really very little harm in using a brace to my mind, and then weaning off the brace if someone is confident and does well after that. So I sense I'm talking to myself, but I'll ask myself one more question that was asked, which was, do you see any value in PRP treatment in treating ACL injuries non-surgical setting? Would you say the regeneration mechanisms works? And likewise, there was a similar question to Mazin, which came on right at the end. Honest answer is I don't. I'd love to see some kind of regenerative biological therapy that works. Most of the studies that suggest efficacy are from people who are proponents, who are conflicted, and they're the lower quality studies. Once you go on to a high quality study, you're unlikely to find a difference, even in the arthritic knees. And that's probably controversial to say, but I think there are many confounders when people go for these treatments. So in principle, when you've done an ACL reconstruction, you've got a knee pretty much full of blood already. So I'm not convinced putting PRP in there is going to make a huge difference, but it is in vogue, and clearly there are some people doing it out there. So I probably should stop talking to myself. Happy to take other questions later, or happy for you to email me offline. We should hand over to someone much more eloquent. So it's time to hear about the unstable hip. And Jonathan Hutt, who's one of my colleagues at UCH and the Princess Grace and ICH, is going to talk to us about a really tricky subject, the unstable hip.
So good evening. My name is John Hutt. I'm a consultant orthopaedic surgeon based both at UCLH and at the London Hip Unit at the Princess Grace. And I'm going to talk a little bit this evening about hip instability in the native hip. We're going to look a little bit about the components of hip stability, and then I'm going to focus a little more on those targets which present themselves as potential ones for surgical intervention. So symptomatic instability really is resulting from extra-physiological hip movement, which leads to symptoms of pain or of giving way. The movement does not necessarily imply extremes of motion, but it also implies problems with pathological motion within the joint. So why does this occur? It must be a combination of either just the structure of the individual hip joint, but more likely in combination with the consequence of activity, and in sport, often a repetitive activity. Many sports require repetitive hip rotation and axial loading, which could lead to problems due to symptomatic instability, either by unmasking a pre-existing structural abnormality, but also more likely from an additional component of an injury to a structure that further compromises the hip stability and leads to progressively abnormal joint motion. Articular cartilage is very poorly affected by shearing force in particular, and there is then the potential for further joint symptoms and injury to occur. It is interesting to note that in athletic individuals, there may be initially at least a potential benefit in the ability to gain a greater range of motion within the hip. And there may even be a higher prevalence of these underlying structural anomalies and certain morphologies in sports which benefited from a greater range of motion, for example, gymnasts and dancers. Let's start by looking at the components of instability. And although there is an increasing understanding of the soft tissue aspects of the hip, it does remain a joint in which a large component of its inherent stability comes from its bony structure and congruence. Now, this is augmented by a number of soft tissue structures, including the capsule, the labrum, and the ligamentum teres. Then there's the dynamic aspect, which is really the muscular envelope of the hip. Disruption of any or any combinations of these has the potential to lead to symptomatic instability, be this by either anatomical design or additional injury, either by accident or iatrogenic. It is also important to consider conditions which lead to generalized conditions of hypermobility. It's important to remember in diagnosis the holy trinity of young hip pathology. The clinical manifestations of hip problems can be very similar in terms of symptoms or provocative examination maneuvers, but there may be some features which are more suggestive of instability, such as symptoms of giving way or features of a more generalized laxity problem. Examination may further reveal generalized signs of hypermobility, reduced capsular recoil, increased range of motion, particularly in rotation, or indeed an abnormal clinical rotation profile. The imaging should evaluate bony morphology, and there's a lot of information to be gained from plain radiographs, but this will need to be supplemented. And in my hands, this involves a CT for 3D morphology, and particularly for an accurate rotational measurement, as well as the MRI for the soft tissue aspects, as well as other components of hip pain that might either coexist or be otherwise missed primary causes, such as AVN or stress injuries, and some of the more weird and wonderful problems. Now, of course, this detailed level of imaging does, of course, introduce other problems, particularly when investigating hips without striking structural anomalies, as you're going to be viewing findings that have a very high prevalence in asymptomatic patients. So I would reiterate the importance of correlation of imaging findings to the clinical picture of history and examination before embarking on a treatment course. It goes without saying that a period of focused non-operative management is advisable in many cases, but this should be guided, I think, by a proper understanding of the underlying diagnosis. If this is unsuccessful, then in general, the surgical targets are the first two pieces of this list, with avoidance of further damage or compromise to the third, and underlying awareness of the contribution of, and really our inability to influence, the fourth. Now, the bony structure is a major potential component of instability, and as such, it's important to evaluate this in some detail. As I said, much of this can really be established from the plain radiograph, but will require 3D imaging for a clearer understanding. Although there are variations in how these measurements are used in definitions, in my opinion, you should consider the risk of instability in the following situations. So, where the CEA, or center edge angle, is less than 25 degrees, where the source sill, or the slope angle of the roof of the acetabulum, is greater than 10 degrees, if there's a clear break in Shenton's line, or on a false profile view, anterior undercoverage is defined by the ACEA. The acetabular wall profile from the X-ray is also very informative. One can consider, for example, anterior instability with a low anterior wall profile, as shown in this case by the blue line, and then demonstrated on CT, or posterior instability in the presence of significant acetabular retroversion, as shown here, where there is a positive posterior wall sign, where the wall is medial to the center of the femoral head, a prominence of the ischial spine in the medial aspect of the pelvis, as well as a significant crossover sign, where the posterior wall shown in blue crosses over with the anterior wall around halfway down the socket in this case. And this is demonstrated here in the 3D CTs, where we can see anterior overcoverage and posterior undercoverage. And I think this is important that we don't interpret this as simply an overcoverage and impingement issue, as the socket overall may be normal or even low in volume, and therefore simply removing the anterior bone to avoid the impingement actually will destabilize the hip, which is already posteriorly unstable. Now, if you're looking at a hip that perhaps lacks dramatic morphology, it's also important to consider the effect of limb rotation resulting from altered femoral or tibial torsion, as illustrated in this case, where we've got relatively normal acetabulometrics and coverage, but significant femoral anteversion, which leads to anterior instability, mainly as a result of that rotation in the femur. Understanding whole limb rotation, particularly in these situations, is very important, as changes further down the limb may be additive or compensatory. And this has consequences, particularly with potential correction, as you may find yourself doing osteotomies at one or two different levels in order to try and achieve the desired effect. Now, thinking about treatment in terms of surgical treatment, in the presence of significant bony instability, and I mean by this particularly acetabular undercoverage, arthroscopy alone is not recommended. And it's perhaps unsurprising to note that in many series, failure rates from arthroscopy are directly related to the degree of deformity in terms of decreasing CEAs, increasing tonus angles, and where Shenton's line is disrupted, which all are really indications of underlying acetabular undercoverage and dysplasia. So moving on now to some of the soft tissue aspects, there is obviously a very important contribution in the hip from the labrum, which contributes both to stability and also to fluid mechanics in the hip, and particularly in smaller movements of the femoral head. Now, labral tears, as you know, are not uncommonly found on MRI scans, and again, it's important to correlate these with the actual clinical symptoms and the picture that's before you. But when we're treating the labrum, we've got a number of options. We can simply debride labral tears, we can resect them, we can repair them, or we can perform partial or total reconstruction. Now, if we look at the data, cadaveric studies show that labral repair performs better relative to the normal intact state than either reconstruction or resection when we were talking about restoration of the fluid seal as well as stability of the hip. And whilst labral reconstruction is gaining some traction, either partial augmentation or even total labral reconstruction, particularly as techniques improve, even in the larger series in the literature, it should be noted there is not any convincing evidence at the moment which is demonstrating it be superior to labral repair. Now, there may well be a place for it with regards to redo or revision surgery with a recurrent labral injury or failed repair, or perhaps even in the primary setting where you don't have a labrum, where it's been absent or attenuated, or in those situations where the degree of injury to the labrum is such that really it's irreparable by standard means. If we look at analysis of predictive features of failure for labral reconstruction, in those groups around the world doing a significant amount, they highlight these factors really as being potentially predictive problems: and higher CAs, increasing tonus grade, increasing age, and increasing BMI. Now, if you look at those, really, what it does suggest is that the failure mechanism may be more related to the fact that there's degeneration in these hips. But again, even in these situations, the evidence is not strong in support of this particular tactic over other, perhaps more simpler options. The hip capsule is another important contributor to stability. It's a condensation of ligaments. It functions as a check rein to both rotational and translational movements. And in contrast, I think, to the labrum, this plays a part in stability at greater displacements of the femoral head during motion. This has implications for both pathological states and also the potential for iatrogenic injuries from surgery. The debate around capsular management during arthroscopy has provided us with important insights into the role of the capsule. Clearly, excessive disruption of capsular mechanics during procedures where there is instability should be avoided. But the other question is whether these additional capsular procedures that are being touted around, such as plication, may have a role to play in cases where instability is a concern. The biomechanical data and experiments performed largely to evaluate the effect of arthroscopic capsulotomies certainly supports the theory that restoring the capsule after injury or surgical incision restores the biomechanics, and does also support the theory that capsular plication by a numerous method does lower the capsular volume. And there are some good short to medium-term results from case series of arthroscopic management of symptomatic hip instability, which include capsular plication, which suggests that in itself it's not a procedure that leads to any detriment. But I think there is a lack of good comparative data to suggest there is additional benefit over other techniques, as understandably it's performed very rarely as a solitary intervention. Those case series which do focus on capsular plication do contain a proportion also of dysplasia patients, and also a variety of other quite significant intra-articular procedures during surgery, which do make it rather hard to tease out the direct effect. So it's notable that even in high volume centres, in those patients with low CEAs, failure rates of up to 20% are described, and there remains a lack of long-term data. And there are other small comparative series of hip arthroscopy looking at outcomes in patients with generalized hypermobility, which do show good results, and much of this is attributed to various capsular techniques. But I don't think the data in itself at the moment can comprehensively prove that this is what we should specifically be doing in these cases of instability. Perhaps one of the more controversial considerations in arthroscopic treatment is the ligamentum teres, and it's worth touching on this. Biomechanical studies suggest that its role in stability is largely in flexion external rotation, as well as extension and internal rotation. But depending on the sort of definitions that you use, injury to the ligamentum might be seen in up to about 50% of those cases at hip arthroscopy. But I guess the real question is there any value in reconstruction? I think the clinical data on this is extremely limited. Even recent reviews on the literature can really only summon a very small amount of patients to analyse. And although the operations did lead to a significant increase in PROMs, it's tempered by the fact that these procedures are often performed as revision surgeries. They have a very high level of additional procedures at the time of surgery, and they continue afterwards to have quite a high subsequent redo surgery rate going forwards. There's also quite a lack of post-operative imaging or biomechanical data to confirm the reconstructions are functioning or whether they're particularly beneficial in the overall scheme of things. And I think the biggest surgical challenge that we face is understanding the difference between each individual component of hip stability and the cumulatively effect of our surgical interventions to each of these parts. Periarticular osteotomy at the acetabulum, the femur, or even both, is a powerful but not benign intervention. And this is important when thinking about young patients with athletic careers. And I'm sure, as all of you know, hip arthroscopy is far from benign in itself. Recovery times can be lengthy. Final outcomes are certainly not evident immediately. And putting all this together, we should clearly aim to minimise the number of potential interventions that we perform in young active patients whose lives will be significantly disrupted by multiple sequential procedures. So just looking at this case here, putting it all together a little bit, I mean, if the bony anatomy is inherently unstable, it seems sensible to kind of alter this rather than simply attack the resulting problems from damage to the smaller structures in the hip. In cases where there is significant symptoms, but the impingement morphology is not particularly dramatic, you should think about the potential for instability and evaluate the rotational profile, consider generalized hypermobility. Arthroscopic treatment may be indicated as long as we avoid causing further problems, retain the labrum, don't over-resect the bone, manage the capsule. There may well be a role for some form of plication in these cases. In revision cases, pincers, hypertrophic or irreparable labra, there may also be a role for labral reconstruction over resection and debridement, if not over repair. But the value for treating the ligament teres, at least, remains a little bit unknown. There are some slightly more complex and unanswered questions, however. If I do an osteotomy at the acetabulum for mild hip dysplasia or more focal undercoverage and I get a good result, would I have got a better result if I'd also performed a labral repair and a capsular plication in every case? And should all of my PAO patients have this? And should they also have a ligamental reconstruction? I'm not sure I believe in that last one, but I think this goes back to my earlier point about trying to pick the right intervention at the right time and to avoid multiple subsequent operations. So in summary, I think it's important when you're seeing patients with hip problems to consider the potential for hip instability alongside other diagnoses such as impingement. I do think it's important to differentiate them and understand the problem with the correct imaging and clinical correlation, as it may well lead you down a different therapeutic path, be it non-operative or operative management. In terms of surgical treatment, I think it's important that we address the bony pathology whilst respecting the soft tissues. And it's possible that some of the newer adjunctive procedures may also have a role. Thanks very much.
Don, thank you. That's very comprehensive and really interesting. I think the challenge often, if you're a physio or a GP or someone assessing young athletes, is what imaging do you start with? When do you get that imaging? And the real problem that most people reporting that imaging won't give the sort of detail you were talking about, particularly in primary care. Can you guide us a little bit with that?
Yeah, I mean, I think that it is a challenge. I think because you get a lot of patients with symptoms around the hips, you know, in sport, and they're not going to turn out to be anything too significant. And I think that it's a recognition that it's when the symptoms are really problematic or persistent, despite, you know, standard rehab protocols, that you're not getting anywhere. And I maintain really that the first intervention in terms of imaging should always be a plain X-ray, because it's not uncommon to unearth a little bit of degenerative change in the hips, particularly as athletes, even elite athletes, get older. And I think once you've done that, you've kind of really understood the problem, and you can stop there. And then for those patients where there is no degenerative change, then these adjunctive kind of images and 3D imaging and in correlation with examination are very important. I think the problem is interpretation is challenging and it needs to be done in a clinical context. So I think some people worry that when they send their patients to a surgeon, the surgeon's going to suggest some surgery. And I do spend an awful lot of my time investigating the patient's hip pain, evaluating where I think the problem is, and then sending them back for rehabilitation with that enhanced knowledge that I think sometimes only 3D imaging can give you. And I think sometimes, you know, it would be a bit unfair to put that all on primary care, and some of it I think has to fall on us.
That's fair enough. And so, if the plain radiographs are normal, is that the time for an MRI scan, or what other investigation would you do? There was a big era of MRI arthrography, which is still commonly used in some areas.
So I'm not a fan of the arthrogram because I'm not sure what additional information I'm getting from it anymore. You know, high quality MRI scans will give me that chondrolabral kind of damage information that I want. And I actually use the MRI mainly to find those things that I can't find in any other way. You know, I don't want to miss a stress injury. I don't want to miss an AVN problem. And I don't want to miss the weird and wonderful. I picked up a couple of osteoid osteomas, which present very much like impingement pain. And I really think that's the value of the MRI. But what it can't do, I think, at the moment, or at least it's more challenging for it to do, is to give you that enhanced information that you get from a CT, where you get the 3D structure, the rotational profile. I do try and hold off on that unless I really think that additional information is going to be helpful, because it is additional radiation. But it is information that at the moment is hard to get from the MRI. And I think that structural information is more helpful from a rehabilitation and surgical planning point of view.
That's great. I've got a great question here from, I wish I could tell who this was from, but I can't. The questions just get relayed as they are. What words do patients use to describe what you then go on to diagnose as hip instability when they present to you?
Yeah, so I think this is really interesting, isn't it? Because you've got to be careful not to put words in their mouths when you're talking to them about pain. So if you listen for long enough, patients with proper instability will tell you that the leg gives way underneath them, and they'll tell you that the hip is painful in positions where it becomes unstable in extension, or when they're standing, or when they're tired. They also tend to complain, and this is why it's difficult to diagnose, a bit more so than impingement. They tend to complain of muscular pain. You know, they tend to complain of gluteal pain, of lateral pain, of overload symptoms of either the psoas or the gluteal tendons. And those are more tricky symptoms to tease out. I do actually ask them specifically about instability, but I try not to kind of have that as my first question.
Now, there's a fantastic question from someone who went to a much better school than I did. Is there anything that a patient might tell you which subjectively, which makes you think the patient has neurokinetic capsulolabral osteochondral dysfunction? So I don't know what that means, but I'm hoping you can answer it.
No, I'm afraid I can't answer that question.
Good, I'll ask you another one. Don't worry, I just thought I didn't understand it, so I would ask you. These osteotomies, very clever things, great corrections, prolong the life of a hip. Do people get back to sport afterwards? What's possible after some of these pelvic osteotomies?
They do. And I don't think the data is huge on this, but you know, there's a lot of anecdotal data of patients returning to activity. I think it really depends where they started in the first place, because you know, some of these patients, particularly the ones with significant generalized hypermobility, you know, you're not going to cure that problem. You're not going to suddenly give them an amazing hip, but you can improve their symptoms. Those people who perhaps are not too generically lax, and they often are, you know, as young patients, gymnasts, dancers, and other sort of high range of motion sports, they do often get back to high level activity. But that is not obviously just the osteotomy. They have to be these patients with great muscular envelopes, good muscular control, and it's that combination that's going to get you to those places.
And last question, because you alluded to it there before we move on to the shoulder. You know, surgery in hypermobility. I've kind of, you know, as I've got older, I've increasingly seen more and more surgical disasters by people operating on hypermobile patients. What are your thoughts? What are your top tips with that?
Yeah, I would agree with that. I think be cautious about what you think you can achieve and what expectations you're going to give the patients. I think soft tissue surgery in hypermobile patients is fraught with difficulty and challenging outcomes. I think if you have a significant bony correction option, then you do have particularly in the hip, the ability to improve their symptoms. But, there are strong caveats as to whether they're going to, really kind of make huge jumps in their outcome scores as a result of it.
John, that's great. In the interest of time, I'm going to thank you there and move on to Carlos. I'm going to give everybody a reminder that we've still got all the panel on. They've all kindly stayed on the call. So if you've got general questions or multi-joint questions, do please put them in the chat over the next 15 minutes and I'll bring everybody on at the end. But for the time being, we will move up the body to Carlos Cobiella, who's a consultant orthopaedic surgeon at UCLH and the Princess Grace, and is really one of the opinion leaders in shoulder instability in the UK. So Carlos is going to talk to us about the unstable shoulder.
Hello, everyone, and thank you very much for attending this session on instability in sport, organized by the ISCH, to which I'm very grateful. And thank you very much to Professor Haddad for inviting me to talk about the unstable shoulder. Shoulder is not a joint, it's a set of joints. And for the purpose of this talk, we'll be talking about the glenohumeral one, which by virtue of its bony anatomy is tremendously mobile, but also quite unstable. So what maintains the stability of this joint? We have passive mechanisms, and the one we think about first is the labrum, although in itself it doesn't provide much stability. What it does is it is the anchor to the capsule and to its thickenings, the glenohumeral ligaments. And the glenohumeral thick ligaments are the ones that are going to act as check reins in different positions of the shoulder, of the arm, and limit the movement, preventing it from dislocating. We then have active mechanisms, and the most important one, interestingly, is actually knowing where your shoulder is in space, proprioception, because that's the basis for the feedback that allows then the muscle control to constantly keep the humeral head centered. And that is referring to the glenohumeral joint in itself and the rotator cuff and its function in centering of the humeral head. But we have to think about this neuromuscular control as a much wider mechanism by which the humeral head is on the glenoid, which is on the scapula, which is on the thoracic wall, and part of the whole kinetic chain. So when dealing with problems with the muscle balance, we have to look at the wider picture. That said, let's talk about how it can go wrong. Ian Bailey described three main types of instability: traumatic structural, atraumatic structural, and non-structural. These are polar types, although on many occasions we'll have patients that will fit in within the triangle as opposed to in the poles. Let's go through them and talk about different types. Traumatic structural, this is the one that we're going to encounter the most in sports. This is people with a perfectly normal anatomy that encounter a force that exceeds the tolerance of the structures that keep the glenohumeral joint in place, mostly the capsule and glenohumeral ligaments in this case. When that happens, we see an X-ray and we think, well, you know, the ball is out of the socket, we put it back in, and that's it. What we're not seeing is the real problem, which is the amount of soft tissue damage that is caused. How do we treat it acutely? Well, it's a surgical emergency and we put it back. But before doing so, please make sure that you make a good neurovascular assessment. Brachial plexus injuries occur in 50% of these events, and of those, the axillary nerve is involved in half of them. Fortunately, most of these are neuropraxias that are either hardly detectable or very transient. It is, however, very important to make an assessment of the whole brachial plexus, and that can be done without causing much disturbance to the patient. Once that is done, it needs to be relocated, and there have been many methods described, most of which involve the use of sheets and burley porters. That's not necessary. Gentle longitudinal traction after the patient is calm and with analgesia if required. If you sustain that traction for 5-10 minutes, you will overcome the spasm of the muscles keeping the humeral head out, and it will just clunk back in. If that is not successful, you can always try putting the patient in a prone position with the arm hanging, with or without a weight, and again, eventually it will relocate. Do we mobilize it? It doesn't make much difference to the final outcome. It does if you do it early, within the first 2-3 days, and in external rotation. That is not something that is well tolerated by patients. This chap is smiling because he's actually had it on for 5 minutes. But when you have it on for a couple of weeks, the common thing is to discard it. So, when I mentioned that it didn't make a difference to the final outcome, that is because there is a rate of recurrence. And that rate of recurrence was described by Havilius and Rowe as being age-related. When they looked at all the factors that affected their populations and compared them, age was the only one that had a significance. And as it turns out, adolescents and young adults are much more predisposed to recurrence than all the population. That's why there is a late problem that requires a late management. How will it manifest? Well, it manifests usually with apprehension, and this clinical test, apprehension relocation, by which we very gradually place the arm in abduction and external rotation whilst keeping a hand in the anterior part of the shoulder, is quite revealing. There is a point where the patient, if they are unstable, will either stop or resist your movement, or the muscles in the chest will start contracting. At that point, stop, because it's easy to dislocate the shoulder at that stage, and applying some pressure with your hand at the front of the shoulder, try and relocate the humeral head. You will then see that the patient's expression relaxes, the muscles in the chest will relax, and everything is much better. That is due to the fact that the anterior capsule is slightly incompetent and the humeral head is translating beyond its normal position and moving forward towards the anterior edge of the glenoid. By relocating it, you restore the stability. If this clinical sign is positive, that patient is recurrently unstable, and nothing short of surgical management will get rid of that instability. Is what it looks like on an MR arthrogram. You can see the contrast tracking between the labrum and the glenoid, and that corresponds to this lesion described by Bainkart, who also described the repair of this capsulolabral complex, which has since been the mainstay of treatment of anterior recurrent instability. At the moment we could do it arthroscopically, we started doing it arthroscopically, and that actually speeds up the recovery of the patient, as we don't have to interfere with any other muscles on our way in. Restoring the position of the labrum will then restore the tension of the anterior capsule and thus stability. But that is if the problem is only in the soft tissues. If we have a problem with bone, then bone deficiency increases the chances of recurrence significantly. And if you look at this paper by Steve Burkhardt and Joe Beer at the beginning of the century, they looked at recurrence in patients that did not have any bony defects in the series was around 4%. If you look at patients that then had bony defects and had a Bankart repair, 2/3 of them failed. That means that part of our assessment needs to include an assessment of the bone, both of the glenoid and the humeral head. The traditional way of dealing with this is through a Latarjet procedure described in the 1950s, and very good procedure, very good at maintaining stability. It's belt and braces. It restores the bony defect with the coracoid. The capsule is repaired, and you then have a dynamic sling that acts as a safety belt and prevents the head moving forwards in the position of instability, abduction, external rotation. However, not every patient will need such an extreme procedure. And I call it extreme because it does have complication rate. It's non-anatomical. It disturbs the subscapularis and can cause problems with the cuff. So, like many things in medicine, we are reinventing the wheel and looking at the work of Eden and Hibbenet at the beginning of the 20th century that described iliac crest allograft augmentation of the anterior glenoid to restore both the bone stock and the stability. Now, the difference is that we can now do it arthroscopically. And by doing that, it not only allows us to assess better the defect and the position of the graft, but also allows us to then do our soft tissue repair on top. So in other words, we are converting a bone deficiency problem into a soft tissue problem by restoring the bone. And we can then deal with it with our labral repair. And this is what we would typically see a year or 18 months after the procedure, where the glenoid has been restored. There has been some remodeling, and in many cases, what you see is a normal shaped glenoid, even if you had inserted a big graft. If the problem is in the humeral head, then other procedures have been described as a remplissage that can actually limit the range of motion and prevent engagement of the Hill-Sachs lesion. So this was the planogram that we were working on until not that long ago. Now we have many more options, and we can actually, there's new procedures described all the time as like this dynamic biceps transfer that actually will allow us to refine the management of these bony defects. So we're in the phase of trying to find the indications for it, and in the very short future we'll have a good management plan. Let's go on to atraumatic structurals. These are basically people that have a predisposition either because their collagen is lax, and or there's dysplasia of the glenoid, or any other condition that will predispose them to this type of instability. It can happen chronically through repetitive microtrauma, particularly in overhead athletes. So you've got tennis players that have laxity. It might end up having a form of microinstability that can manifest as impingement, but also as instability itself. They can have associated structural damage, and that also, or it happens more often in patients that do then have an injury. And that can include Bankart lesions, Hill-Sachs lesions, cuff problems. The management of these is usually non-operative, and the aim is to enhance dynamic stability to get them back to activity. But sometimes they require operative treatment to deal with a structural problem to then get them into their rehabilitation program. And that would include repairing bone defects, haggles, or labral problems. This group, the type 3s, are non-structural, they're positional, and this is a group that we should be very wary with. These patients have muscle patterning disorder, and it often starts as an involuntary problem, and they're able to clunk their shoulders in and out. The main difference with the others is that if you look at the joint, you will find that there's no structural damage. And if you go in to perform a stabilization, and you see that there's no structural damage whatsoever, come out and put these patients in the hands of physios, which will work on postural control, core stability, sensory feedback, quite important, and proprioception. And although it's not easy, they can get rid of it. So in summary, instability happens for many reasons in the shoulder. It's mostly traumatic and structural, and the patients that have recurrence can be dealt with appropriately with a combination of both rehabilitation and surgical interventions. Thank you very much.
Thank you, Carlos. Great job. A few questions for you from the audience. Some patients with recurrent shoulder dislocation are not troubled by it. Do they need treatment?
When you say they're not troubled by it, you mean that they basically can relocate the shoulders themselves and they can get on with it. Unfortunately, recurrent dislocations do take a toll on the articular surface, and the rate of chondral degeneration increases with the number of dislocations. So I would say that it does cause a problem long term, even if they can manage it in the short term.
All right, that's a very clear answer. Carlos, you focused on anterior instability. How common is posterior instability?
That's a good question. Posterior instability has traditionally been thought of as being rare. The truth is, it's not been diagnosed enough. It is not that uncommon, and the management is very similar. It's basically usually due to failure of the posterior capsule, and that can be addressed similarly. When we're talking about other types of instability, type 2s or type 3s, the direction is not that important, and the dynamic stabilization works on the whole of the joint.
All righty. In terms of investigation, I may have missed it. John told us that the hip guys have learned that the arthrograms don't really help much. It was a bit of a fad, and now it's gone. In the shoulder, are you still using arthrograms for the MRIs?
Well, with the advent of 3T MRs, that has been much less of an issue. Getting an MR arthrogram implies the use of a radiologist and the time of a scanner, and coordinating both is not easy. So I tend not to use arthrograms unless I'm looking specifically for superior labral problems or even posterior ones. For standard anterior instability, I don't particularly need an MRI, to be honest. If I have a clinical confirmation of anterior apprehension and a positive relocation test, that means that the problem is structural and will require a surgical option. And then once we are surgically engaged, we can then assess the amount of bone loss and the kind of procedure. If we want to plan beforehand, an MRI is useful.
That's great. Last question for you, Carlos. Does Mr. Cobiella have any information on the development of breathing pattern disorders in patients following instability of the shoulder complex?
That's a good one. No.
There you go. Easy question, easy answer. Excellent. I think let's bring back the whole panel. I've got a question that's come up here that I think is excellent and very pertinent to everyone. How influential do you find the menstrual cycle on the onset of acute instability injuries? So maybe for each of you, let's go around in order, starting with Nick. Maybe some thoughts about whether the menstrual cycle, do you think, has an influence on injury rates or presentations in the foot and ankle world? And then one final message from you, and then we'll go down to Mazin and then John, and then back to you, Carlos. So any thoughts, Nick? I know it's common in the ACL world, lots of discussions. around the influence of the menstrual cycle, and certainly in the spine world and so on. What about in the foot and ankle world?
Well, I haven't seen anything associating ankle sprains with the menstrual cycle. Certainly very interesting. It's something I'll look out for. Certainly the sort of perimenopausal, we see lots of problems around there, but the associated with the menstrual cycle, there's nothing I've seen about that.
Cool. And having heard the other presentations, Nick, before I pose that question to Mazin, any key messages you want to flesh out? The one I took away from your presentation was clinical examination trumps the scan.
I think that's exactly right. The scans don't tell us anything about stability, but they can be really helpful as an adjunct. And setting out a plan early on as to what time of out of sport we're looking at and how long it's going to take to recover from the injury is helpful in setting expectations as well.
Perfect. Thanks, Nick. And if anybody has more questions for Nick, you'll be able to get him through the Princess Grace, and him and the rest of the foot and ankle unit will be happy to answer questions. So Mazin, I think you're struggling with your video. Thoughts on the menstrual cycle and knee injuries?
Well, as the question was asked, I was looking actually online on Google, check if there is any relationship between that, because I haven't come across this. And to be honest, I can't see that there is much link. However, there is some link discussed in some of the publications about changes in the muscle bulk, especially the VMO, and whether this can cause weakness, and this can be changed according to the menstrual cycle. But I have to go through details. I'm happy to read about it, and I'm happy to be asked again.
No, I mean, there's certainly is a literature around the ACL, Mazin, so it does exist. I think it's probably relevant. Let's jump across to John. Any thoughts from the hip perspective on that?
Well, I mean, again, it's not something I've directly recognised. I think a lot of hip instability is in young female patients, but I haven't noticed that they would, yes, the actual sort of impact on the menstrual cycle and their symptoms in particular, I have to say, no.
All right,
Not, it doesn't happen, but
more to look out for. Thanks, John. And Carlos?
Well, there is no particular literature that I'm aware of that talks about the subject, but there is no doubt that the hormonal environment does have an effect on collagen. And it would be logical to think that changes in the cycle and in certain moments of the cycle, they might be more predisposed to these injuries. Again, something to look at and maybe investigate.
And one last question for you that's just popped up on my screen. The painful shoulder in primary care, you're assessing clinically. What's the key test that'll tell you it's unstable as opposed to impingement or a cuff tear? Is that your apprehension test, or is it something else?
Well, apprehension test is definitely a good way of finding out if there's anterior instability. But at that stage, if it is positive, you'll know that there is a problem from the history. So a good history, good examination, there isn't a single test in the shoulder that will give you all the answers. Yes, the apprehension test is quite useful for instability.
All righty. Well, thank you, Carlos. Thank you very much to Nick, to Mazin, to John Hutt, as well as Carlos, and to the team at Kelly Starling's team at HCA, and to Craig and his team for putting on the webinar this evening. Lots of interesting presentations, hopefully stuff to think about. I think the key thing, as I said for Nick, is that Mazin, John and Carlos and myself can all be contacted directly if you've got specific questions that we haven't been able to answer. It's a little bit strange our end because we can't see you and can't see who's asking the questions, and therefore perhaps aren't understanding your questions because they're relayed by a third party, but we are obviously happy to link in offline as needed. But thank you for listening, for attending, and for asking the questions, and I hope everybody enjoys the rest of their evening. Thank you very much. Thanks to all the speakers.